Today we're diving into a really critical case report. It's about a sudden cardiac death in a dog that happened right after a blood transfusion. A procedure we do all the time. This case is a huge reminder of the hidden risks in our daily practice. So let's really break down what happened here.
Hey everyone, welcome to The Explainer from Veterinary News. If you find these deep dives into cases like this valuable for your practice, do me a favor, hit subscribe, and definitely drop your thoughts in the comments below. All right, let's get right into it, because this is a case that really highlights the complexities we face every single day.
So here's the question that this whole case forces us to ask. It's the kind of question that, honestly, keeps us on our toes, right? We do blood transfusions to save lives. It's a cornerstone of emergency medicine. But this case is about that incredibly rare, catastrophic moment when that life-saving procedure might actually trigger a fatal event. So how on earth did that happen? Let's dig in.
Okay, so to really get why this had such a tragic outcome, we have to start with the patient. This was not a simple case from the get-go. There was a really significant underlying condition that kind of set the stage for everything that was about to unfold.
So let's meet our patient. We've got a 14-year-old, male-neutered Amstaff. He first came in because of a new heart murmur. The workup showed myxomatous mitral valve degeneration. Pretty common stuff, we've all seen it. And importantly, no cardiomegaly. But the really critical finding was waiting on his ECG.
And here it is. The dog was diagnosed with a high-grade 2-to-1 second-degree AV block. This was causing a pretty significant bradycardia, with his ventricular rate hovering around just 60 beats per minute. Now this underlying electrical instability is the absolute key piece of the puzzle. You got to keep this in the back of your mind as we go forward.
All right, so fast forward just 1 week from that cardiac workup, and the whole situation just escalates dramatically. The patient shows up at an ER facility with an acute, full-blown, life-threatening crisis.
He presents for weakness and collapse. And the signs were classic, right? Pale gums, painful abdomen. We all know where that story is likely going. Sure enough, an ultrasound confirms a hemoabdomen from a ruptured splenic mass. He was rushed to surgery for an emergency splenectomy. Now, the surgery itself went okay, but the aftermath, well, that was a whole new problem.
And these post-op numbers really tell the tale. His hematocrit, which was 32% before surgery, absolutely plummeted down to 19%. That is a massive drop into severe anemia, and that is what drove every decision from this point on.
So even after he went home, the weakness and collapsing just didn't stop. His body just couldn't compensate for that blood loss. You've got this severe anemia, and you pile on top of that his pre-existing bradycardia from the AV block. He just couldn't get enough oxygen delivered where it needed to go. It was clear that a much more aggressive intervention was needed.
And that brings us to the logical next step to deal with this symptomatic anemia. But, as the title here suggests, the very intervention that was meant to save him, well, it had a completely unforeseen and tragic consequence.
So, a packed red blood cell transfusion was recommended. The goal was simple, and it was the correct one. Let's boost his oxygen carrying capacity to fix the weakness and collapse. I mean, this is standard of care. It's textbook.
Okay, let's walk through this timeline because the timing is everything. The transfusion starts at 8:50 p.m. It finishes up about 3 hours later. But look closely. It's about 90 minutes after the transfusion is completely done that the fatal arrhythmia kicks in. And just 4 minutes after that, he arrests.
And there were other huge red flags that something was going terribly wrong. You'd expect a transfusion of this size to bump his HCT by more than 10%. It only went up by 4. That's a really poor response. On top of that, his plasma was noted to be hemolyzed, and clinically he got restless and tachypnic. I mean, those are all classic signs screaming transfusion reaction.
So we know what happened clinically, but what was actually going on electrically inside the heart? This, my friends, is where this case becomes absolutely fascinating because we have a complete recording of the heart's activity before, during, and after this whole event.
Now, in what you could call an incredible stroke of clinical foresight, or maybe just some really good luck, a Holter monitor had been placed on the dog before the transfusion even started, specifically to keep an eye on that known AV block. This single decision basically gave the team a black box recorder, capturing every single heartbeat and letting them do a detailed post-mortem analysis of what went wrong.
And the Holter data just lays it all out. Look at this. At 10 p.m., at midnight, during and right after the transfusion, the rhythm is stable. Nothing's going on. And then, around 1 a.m., the ventricular activity just explodes. It goes from 0 to 80 in an instant. The key here is that this life-threatening arrhythmia started a good hour and a half after the transfusion was over.
So this electrical storm, it started with just a few single VPCs, but it rapidly, and I mean rapidly, degenerated into couplets, then triplets, and then finally into sustained runs of a particularly nasty rhythm, polymorphic ventricular tachycardia.
And the morphology of this VTAC was a dead ringer for torsade de pointes, the twisting of the points. As clinicians, the second we see that pattern, our brain should immediately scream long QT interval. It points to a huge problem with cardiac repolarization, and this specific diagnosis is really the key that unlocks the whole mystery.
And once torsade de pointes took hold, it was a tragically short path. Within just 4 minutes of that sustained VTAC, the rhythm just fell apart into ventricular fibrillation, just that chaotic, useless electrical quivering, and that led directly to cardiac arrest. Resuscitation efforts were started, but unfortunately they were unsuccessful.
So we get to the final, and really the most important question. Why? What on earth caused this? The authors of the report proposed that it wasn't just one thing, but a multifactorial cause. A true perfect storm of conditions that all came together at the wrong time. So here are the 3 big theories. First, citrate toxicity. The idea is that the citrate anticoagulant in the blood bag itself chelated, or basically sucked up, the dog's ionized calcium and magnesium. That electrolyte disturbance is a known cause of a prolonged QT interval. Second, all signs point to an acute hemolytic transfusion reaction which caused hypoxic injury to the heart muscle itself. And third, and this is the foundation for everything, was that underlying AV block. His heart was already slow, already electrically predisposed to this kind of problem. It was basically a tinderbox waiting for a spark.
And if you want the smoking gun for that long QT theory, this is it. This data comes straight from the Holter analysis. Look at the corrected QT interval. It's stable through 11 p.m., but by 1 a.m., right before the arrhythmia storm began, it had dramatically and pathologically shot way up. This is objective proof of severe electrical instability.
So what's the big takeaway for us in the trenches? The authors wrap it up with this crucial point, and it's worth hearing directly. This case report highlights the need for monitoring electrolytes, ionized calcium levels, and potentially continuous ECG monitoring in dogs during and after blood transfusion. And I would add, especially in any patient that has an underlying cardiac rhythm issue. This case is such a sobering reminder that even our most common, routine procedures can carry profound risks. So the final question I'll leave you with is this. Based on what you've just seen, how will this case change the way you approach and monitor your very next transfusion patient, especially if they have a cardiac history?